everyone. This is Phil Walls at myMatrixx. Thank you very much for joining our webinar this afternoon on Understanding Pain Management Requirements. The webinar today is going to run about 1 hour. We'll try to keep the content to about 50 minutes or so and hopefully allow us time for some questions at the end. Please be aware that you can receive 1 hour credit today for your adjuster license, case management, as well as nursing licenses. We will have more information on that at the end of the session. Also, any questions that you have, we will attempt to answer as many as possible at the end of the session. We do have over 600 registrants today, so if you could submit your questions to us in the question and answer box located on the bottom right-hand side of your screen. Now, by way of introduction, of course, this is Phil Wall speaking. I'm the Chief Clinical and Compliance Officer at myMatrixx. I'd like to introduce everyone to our first panelist, who is Dr. Stephen Stanos. Stephen has been a friend and colleague of mine for almost a decade now, and his role with myMatrixx is as Medical Director. Dr. Stanos is also a practicing physician at the Swedish Medical Center in Seattle. And then also joining us is Jaylene Fahey, whom I believe many of you already know. Jaylene joined us as our Director of Compliance and Government Affairs. Now for the agenda, there is a lot of information available regarding pain management guidelines, regulations. So we're going to try to focus on some key areas that we feel will be of interest to all of you. First, we're going to start with a recap of the opioid crisis and the treatment of pain. Then we want to look at the current regulatory environment as it pertains to pain management. And we've broken this down into what the medical boards are saying, what workers' compensation is saying, and then we're going to look at prescription drug monitoring programs, which have also been very prominent in the news recently. And then finally, we're going to do a 2014 regulatory overview. Now, I would be shocked if there's anyone in the audience today that is not aware of the opioid crisis this nation is facing. It's a very tragic situation. Many of you have heard me speak on this. Many of you have probably heard Dr. Stanos address this topic. And at the same time, we still hear about cases of undertreatment of pain. There's many ways of looking at this, and we're going to try to cipher through all this today. But equally prominent in the headlines recently has been activity from the Drug Enforcement Administration, the DEA. They have looked at 2 drugs in particular, both of which are opioids, and they have recently rescheduled those. And I would say over the last 2 weeks, that has probably been the #1 question that I have received is, what does this mean to workers' compensation? Questions have ranged from, is this going to decrease utilization of these drugs? Is this going to actually increase office visits? So, brief outline, first of all, when it comes to the hydrocodone combination products, and we're referring there primarily hydrocodone with acetaminophen, generic Vicodin, generic Nortab, etc. That has been moved from a Schedule 3 to a Schedule 2 category. The primary impact on the treating physician is that he or she can no longer write refills for these prescriptions, and they cannot phone or fax the prescription into a pharmacy. The patient must have a new prescription each time. So one way of thinking is it would be ideal if the extra burden actually decreased the use of this drug. But I remind the audience, keep in mind how many Schedule 2 drugs we're already dealing with in workers' compensation, OxyContin probably being at the top of everyone's list. The Schedule 2 status doesn't really impact the utilization. But let's take it a step further. Is that really the DEA's role? Are we depending on the DEA to try to manage medical practice? And the answer is no. The DEA is charged with trying to control diversion of these very dangerous drugs. And one tool that they have to accomplish that is through scheduling. With regard to tramadol, that has gone from being a non-controlled substance to a Schedule 4. The limit there from the DEA is no more than 5 refills in a 6-month period. One last comment on this before we move on. This now means that all opioids, with the exception of one, are controlled substance. That one exception is actually an over-the-counter drug, dextromethorphan, which is the DM component in a lot of over-the-counter cough syrups. It's a very dangerous drug. It is an opioid, but it not only is not controlled, it is over-the-counter. So with this, probably the next most common thing I hear from our clients is the frustration over why doctors don't follow guidelines, and what can we do about that? So on that note, Dr. Stanos, I'd like to turn it over to you to address where we are with this major public health problem.
Thanks for having me, Phil. And I have to just comment on definitely what you had said previously with this whole issue with the opioid crisis. It's obviously a problem, and we still always have to remember on the other side in balancing undertreatment of pain. Hopefully with a lot of things we're going to talk about today, I think it underscores that a lot of different stakeholders are getting involved, and hopefully with their input, whether it be state medical boards, new guidelines, and even changes with the DEA, that's hopefully going to decrease this crisis, and hopefully we get back to safer prescribing for patients. With that, I just wanted to give some background for the rest of the presentation, and Phil commented a bit on the opioid crisis. I think we need to go back to the late 90s when there was a significant increase in prescribing over a 10-year period. Prior to that, mostly what physicians were writing were meperidine, Tylenol with codeine products. With the increased marketing of OxyContin, I think there was a false sense of security about risk of addiction and abuse. We saw the significant increase in overdose deaths. What's interesting was in 2009-2010, there was a SAMHSA survey of college and teenage students, which is a quarterly questionnaire that goes out. And what they found from that was that there was a significant increase in recreational use of opioids, which I think before had been somewhat ignored. And I think that's the other thing to remember is we have this opioid crisis related to prescription overdose and misuse of medicines. It involves both recreational users, drug abusers, and pain patients. And so that needs to be considered. Interestingly, with the non-medical use of prescription painkillers, the cost also has increased. A number of estimates are up to $70 billion annually. If you look at just the long-acting opioids, that cost is about $11 billion per year. Phil mentioned the change in scheduling with the hydrocodone combination products. Those products alone are responsible for 130 million scripts. That's the most prescribed medicine in this country. So it'll be interesting to see with the change in scheduling how that's going to affect misuse and prescribing in general. Next slide. So I think it's important to always discuss about risk management, and Phil mentioned that the DEA is involved not really in the regulation of the practice of medicine, but hopefully decreasing risk, and they've been doing this for a long time. The Controlled Substance Act came about in the 1970s. One of the first big impacts was the package insert. Prior to that, we really didn't even have package inserts. It was hard to distinguish between prescription and over-the-counter medications. Risk management itself has evolved over time with problems that we've seen in medicine. And in the late 90s, medication guides were developed. Medication guides are that one-page description of a medicine that's stapled to your pharmacy prescription when you pick it up, and it just goes over the basic indications for a medicine, the potential side effects, and that was done as a means of helping to educate patients. So I think physicians are sometimes intimidated by the term risk management, but they have to understand that these are done for good reasons, and most of it is to decrease misuse harm that many of these medications that in some cases can be a benefit to patients but also can be at risk. And I think we can agree with opioids. There's definitely a percentage of patients where there can be problems with these medications. So risk management has evolved because of the problems in 2000, mid-2000s with increased overdose deaths. Next slide. The government decided to put a risk evaluation mitigation strategy, which is really a stricter risk management program, which in the past was placed on a medicine if it was found to be potentially dangerous to a patient but still of benefit. I think the example was something like Accutane. Accutane is a good medicine for acne, but it also can be very toxic. So there's registries, there's limited prescribing of the medicine, and it has its own individual risk evaluation mitigation strategy. What's interesting with the opioids, the DEA, the FDA decided to put a risk evaluation mitigation strategy on an entire class of medicines, in this case long-acting and extended-release opioids. And so that was developed in 2013. There's been courses now that are unfortunately voluntary, but may in the future become mandatory and based on physicians getting their license renewed. But these courses are 3-hour courses. They have a blueprint that was decided by the government, which gives an overview of what should be done with regards to assessing patients, monitoring patients appropriately, and hopefully with this education, that also is going to help decrease misuse of these medicines. So the REMS has been established. We're seeing some small percentage of physicians that are going to these courses. A lot of the guidelines we're going to talk about later this afternoon are based on the blueprint that the government felt was important for all the educational programs. And those can be at individual meetings with presenters or online. Next slide. Just for more background, in response to the increase in overdose deaths, a group of physicians known as Physicians for Responsible Opioid Prescribing, led by Drs. Kolodny and Dr. Franklin, and some of the leaders in the field, actually came out with a pretty strong statement and petitioned the FDA to change the indication and marketing of long-acting opioids. And this led to a 2 or 3 year process and a recent response late last year from the FDA. Next slide. And what Prop was talking about, and Prop, again, somewhat controversial, they proposed 3 very strong requests. One was to strike the term moderate from the indication for non-cancer pain. Most of the opioids are indicated for moderate to severe pain. The second was to add a maximum daily dose equivalent to 100 milligrams of morphine for non-cancer pain. And the third and final was to add a maximum duration of 90 days for continuous use for non-cancer pain. Now, once this petition was submitted, there was public hearings, there was feedback from a number of the pain societies, and again, late in 2014, a response was made in September through Prop. And what they did was the DEA came out, or the FDA came out, and did not agree with the 3 requests, but did make some modifications. With the first, they did not strike moderate, but they did change the actual indication for long-acting opioids, which I'm going to show you in a second. Second, they didn't feel that adding a maximum daily dose, an equivalent of 100 milligrams, was appropriate, that it was hard to set limits based on epidemiologic data, and there was significant variability from patient to patient with regards to prescribing, and that patients could respond at lower doses as well as higher doses. The third, they didn't feel that it would be adequate or appropriate to limit prescribing of opioids to 90 days. And I think the emphasis was more on how do we better educate physicians to do better screening and better management of patients that may be good candidates for opioid management, and how do you monitor them for the long term. I think what was important for number 3 was that they didn't feel that, they felt that this could lead to untold suffering, because there are still legitimate patients that can do well on opioids. Obviously, they need to be very closely monitored. Next slide. So the new indication for long-acting opioids are for the management of pain severe enough to require daily, around-the-clock, long-term opioid treatment, and for which alternative treatment options are inadequate. So this, ups the ante on the description of who is appropriate for an opioid. And here, I think it's important that they use the term, where alternative treatment options are inadequate. So again, not just the patient has pain and they need to be put on an opioid, that they need to really be assessed appropriately and have failed other treatments. Next slide. Going into a little more detail, they also explain that these drugs should be reserved based on the increased risk of addiction, abuse, and misuse. So very clearly stating the risks, whereas before these risk of abuse, addiction, and misuse were maybe in the package insert, but not in the actual warnings. So again, I think this again upped the ante of the importance of understanding the risk with these medications, and that they should only be used in patients that have failed other therapies, or those therapies were found to be ineffective or not tolerated. Next slide. Within that, they also included a specific box warning, which had never been done before, and they highlighted 5 important areas. These 5 areas may have, again, been parts of package inserts in the past, may have been understood as potential risks, but here they're highlighting this as a significant box warning, again, that would affect what a physician should understand when they prescribe, as well as when they get informed consent from a patient. And what they highlighted were, this is an example from the Zohydro ER package insert, but this would be for all long-acting extended-release opioids, branded and generic. And it highlighted 5 areas. 1, that there's a risk for addiction, abuse, and misuse. 2, that life-threatening respiratory depression is a risk, and again, most of the deaths are related to respiratory depression. 3, accidental exposure, especially in young children, getting a hold of a fentanyl patch or taking a long-acting opioid or short-acting opioid for that sense, could lead to toxicity and death. 4 was the risk for neonatal withdrawal, and I think this has increased physicians' acceptance and understanding they need to many times take patients off opioids that are pregnant or be able to better manage in a tertiary center neonatal patients that may have opioid dependence. And 5th, the interaction with alcohol due to the risk for potential dose dumping and the synergistic effect of alcohol, that patients taking long-acting opioids should not be drinking alcohol. So again, those were important that they were placed in their own specific boxed warning. Next slide. I just want to comment quickly on doctor shoppers. I think, again, this was another key factor in some of the problems that we saw with overprescribing and misuse of opioids. You know, a doctor shopper is a person. Many times they're not patients, but they obtain multiple scripts, mostly from unknowing physicians or physicians that may be egregiously involved. These doctor shoppers are getting meds from multiple physicians. We saw the highest increase in doctor shopping in maybe 3-4 years ago. If you think back to that time, we had limited prescription monitoring programs, and really these persons that were performing illegal acts were really finding gaps in the healthcare system that they could take advantage of. This one study looked at doctor shoppers, and they looked at a million prescriptions, 146 million prescriptions. They were able to show actually that the doctor shoppers were a very small percentage. They only constituted maybe 1 in 143 patients, but of that small number, around 0.7%, they purchased up to 2 to 3% of all the opioids. And this other study actually looked at the different subsets of these prescribers, and most patients that received prescription opioids, 80 to 90% were prescribed for 1 script that they didn't renew. They probably were given this for acute pain. The other 10% were primarily what we would see in pain clinics, where patients may have gotten a script from 1 or 2 providers over a year, from a primary care doctor, from a pain specialist, and then this third group, or the extreme group, and these were probably the doctor shoppers. So again, a small percentage of patients, but I think where there was a lot of press, and we saw significant deaths because a lot of these people would get a hold of these medications, and then these were routed through illegal acts, and we saw increased deaths, many times with drug abusers as well as recreational users. Next slide. And another study I just want to highlight also looked at the age and trying to identify a profile of these doctor shoppers. Most of them, as you can imagine, were 30 to 35 years of age, kind of similar to the age that we'll see with our workers' comp patients. So again, I think it's just important to understand, yes, there's doctor shoppers. Hopefully with some of the things that have been done with regards to prescription monitoring programs, guidelines, those types of things are going to really limit this. And we've already seen in some states a significant reduction with doctor shopping as well as with pill mills. So I just wanted to highlight that. Next slide. Still, we saw an increase in overdose deaths. I think that's what the government was even more concerned about. Over time, you saw a lot of education at the population level to teach the communities about prescription overdose. Next slide. We still saw an increase in prescription overdose deaths, and I think this slide shows the number of deaths increasing. Actually, in 2010, there were 38,000 overdose deaths. At that time, it was greater than traffic fatalities and gun homicides combined. 2010, the number was up to about 17,000 deaths presumed to be related to prescription opioids. And this is the reason why we saw such a strong reaction by the government to try to do something about it, which obviously is appropriate. Next slide. Just one last part I wanted to touch upon, what's the risk factors? And a lot of times in medicine, we're looking for risk factors for misuse, abuse. What are those? And what they found was for overdose deaths, it was probably with doctor shoppers, low income and rural residents, many patients or persons with a mental illness history and substance abuse history. I think in one state, the state of Washington, 45% of the deaths 1 year of those patients were on public assistance. So again, maybe that's an area that education and better clinical judgment needs to be focusing on. Next slide.
So, Dr. Stanos, before we get into some of the policies and guidelines that are being put into place from medical boards, workers' compensation, and some of the statewide initiatives, I'd really like the opportunity to ask you some very specific questions since you are a treating physician. First of all, a comment. When you were referring to PROP and the recommendations that they had made to the FDA, I was very disappointed that the FDA did not follow those. And I know they have their own statement that, well, you know, the opioid should only be used, especially the long-acting, if an alternate therapy is inadequate. But I think that's a very subjective statement. So as a practicing physician, how do you determine when it's really necessary to institute opioid therapy versus trying other therapies?
Well, I'm a physiatrist by training, and I work in a functional restoration program. So we're, you know, using other modalities, whether it be physical therapy, occupational therapy, psychology, other interventions, and we use other medications besides just opioids. So I think it's really a balance, and many of the patients that are referred to us, I think unfortunately are just put on opioids because that's the only thing the physicians know how to treat pain, or they think that's the only thing, and so then the patient kind of gets stuck. So I think unfortunately early on in treatment, there's been this kind of knee-jerk reaction to go to an opioid when a patient has severe pain, but hopefully with a lot of these changes that we're seeing, I think physicians are getting a little better educated that there are other things they can use. And, you know, unfortunately, like I tell every patient, any medication, whether it's an opioid or an anticonvulsant or even an anti-inflammatory, those medications aren't going to take your pain away. And unfortunately, I think our patients may think that they're looking for the magic pill. And physicians, I think, sometimes have just gotten a little lazy and kind of just said, well, opioids are a strong analgesic, I'll just use that. So I think you need to look initially at other options before you kind of make that leap that patients are on opioids. I think the other issue, too, is that many of these patients didn't do well with the trial of the opioid, but they maybe had a small reduction in pain, and the physician still felt that that was enough to keep them on the medicine. I think a lot of the guidelines we're going to talk about really push the idea of doing a trial over a short period, whether it be a number of weeks or months, and if it doesn't work, then you take the patient off. Or I think in the past, patients were placed on opioids, and if they had a small response, they would be kept on them indefinitely without really a reevaluation.
Very good. Thank you for that. You used a phrase that many of the patients seem to get stuck. And I think in workers' compensation, I think among our audience, the fear is that way too many patients get stuck. I know in the past you've described for me how when a patient comes in, you can pretty well tell very early on if someone is truly in need of therapy, whether it's opioid or otherwise, or those that may have ulterior motives. Could you describe some of those cases for us?
Yeah, we could have hours talking about some of these patients. I think it's important, like you mentioned, you know, when the patient comes in, unfortunately this is a very unique area of medicine where the physician's trying to figure out, you know, one, is this a legitimate patient? You know, is their pain real, which is sometimes hard to pick up on? And then you're considering, is the patient diverting? Are they selling half their meds and taking the other half? You know, those issues come up. Rarely in medicine do they really have to deal with those other kind of questions as a physician. So I think that's the big issue, is trying to do the assessment. I think a lot of patients that come in, and I'm speaking from being in a tertiary care center, they've been put on an opioid, and they may get an anxiolytic effect from the medicine. It may be a small response, and that's where they get stuck. And many times the psychologic factors, depression, anxiety, with a legitimate patient, are ignored. And then we wonder why the patient's not doing well, yet they still want to continue to take the medicine, even though they're probably just getting more of an anxiolytic effect. I don't think they get euphoria after time, but they get some kind of reward from it. So there's the whole reward property of an opioid that if you don't assess patients closely, I think that's where we see some of the problematic use, or the use that's not appropriate. You know, not all use has to be problematic. It may just be that if they're not really getting a true benefit from the medicine, there's other adverse effects that you need to be monitoring for as well.
Okay. One last question while we're at this point. There are two tools that we hear a lot about. One is accessing prescription drug monitoring program databases, the PDMPs, and the other is the use of urine drug screens or urine drug tests. Could you comment on the practicality and the usefulness of both of those?
Well, I think it's like anything in medicine, especially in pain medicine, is they can be very effective, prescription monitoring programs and urine screens. You know, in the past, there was maybe a handful of states that had prescription monitoring programs. I practiced in the state of Illinois. We had patients from locally from Wisconsin and Indiana. You couldn't get information from other states. The prescription monitoring program really helped, I think, especially with doctor shopping. So you can quickly rule out, it's not perfect, but you could quickly rule out a problematic patient, get the report on that patient before you even walked in the room with the patient. So I think those have been helpful. Urine screens have been helpful as long as they're not overused. You know, we try to screen patients and do an assessment with the patient, and I'm always amazed of what the urine screen still comes out with. But the urine screens have, again, I think have been used as a tool. The key is multiple tools together are hopefully going to help you in screening patients effectively, and not one tool in itself is going to be perfect. That being said, even urine screens, you know, understanding how to properly do a urine screen is going to be important. So going back to your question, I think they're both have been very helpful, but again, you still need to be assessing patients. You really can't use that as your only tool to monitor patients for misuse or abuse of their medications.
Okay, excellent. Thank you very much, Dr. Stanis. Why don't we move on now and talk about some of the pain management policies that the medical licensing boards are looking at.
Well, you know, I think it's important, and this slide here, you know, highlights the FSMB, the Federal State Medical Board Model Policy. That was developed by Scott Fishman and others a number of years ago. Very well-written documents. The goal of this was, by the FSMB group, was to inform and better educate the public, as well as improve healthcare providers' knowledge of prescription opioids and how to prescribe. And I think most state guidelines are based on most of the components of the Federal State Medical Board policy. Like other guidelines in groups, they've updated and adjusted their guidelines. From 2004 to 2013, there was a significant emphasis in increasing how patients or physicians should assess patients, how they should monitor, how we should educate the public, and even tools to use. So I think as this whole process has evolved, groups like the FSMB policy have evolved as well. And I think the key there is the balance between appropriate prescribing and you know, making sure that patients are still being getting pain management that they deserve, those appropriate patients. So really, the FSMB is a framework for legitimate use versus, you know, the professional and ethical responsibility that a physician has in prescribing these potentially dangerous medications. Next slide. And I'm just going to touch upon, you know, different states and different workers' compensation groups have approved guidelines. I practice in the state of Illinois. We had no guidelines, so unfortunately, it's going to vary from state to state. And also, it's going to be important for physicians or clinicians in those states to understand what's going on. I think many times where there are guidelines in a state, many times the physicians themselves aren't aware, or they may just be aware of a couple of the political issues surrounding the guidelines. But if you read through many of the guidelines, they're very practical. I'm not going to say I agree with everything in every guideline, but they are, I think, a good source of reference for physicians. Many of them are based on the ACOM guidelines, ODG guidelines. But again, I think, you know, they just have to be, physicians have to be familiar with them. There are variabilities within these guidelines. I think some states have dose limitations, some 80 milligrams, some 120 milligrams, because there's a thought with increasing dose that there may be an increased death. I think that maybe sometimes leads to a false sense of security, but at least in many states, if you get at these higher doses, they mostly recommend that these patients be seen by a specialist to better evaluate or do a consult on the prescribing. So again, we're going to go into a little more details about these guidelines, but I think, again, if they're used in the right manner, they can be very valuable. Next slide. And this is just an example from the myMatrixx website where we've been able to break down different states if they have a workers' compensation treatment guidelines We've also broken down what those were based on, some of the additional pain management statutes or regulations. And I think this is a good resource for all clinicians and prescribers and people that are involved in potentially doing reviews of drug regimens on what those local state guidelines are. So again, I think it's important from the call, if you have a couple of minutes to spend time going through and familiarizing yourself with some of these guidelines. So with that, I want to transition back to Jaylene. She's going to go into more detail about the recent multi-board and statewide initiatives related to these guidelines. Jaylene.
Thank you, Dr. Santos. Yes, in 2014, there are 3 states, Colorado, Pennsylvania, and Tennessee, that have released guidelines. In Colorado, it's a quad regulator opioid policy, and the 4 boards that were involved are the medical board, the pharmacy, nursing, and dental examiners board. Like Dr. Santos was talking, a lot of this is just educational and reiterating best practices. The Colorado guideline directs physicians to use PDMP, to use evidence-based practices, emphasizes the importance of patient education with regard to appropriate use, storage, and disposal and risks, and also encourages collaboration with the integrated health team to decrease overprescribing, misuse, and abuse of opiates. In Pennsylvania, Governor Corbett established a 70-member task force to analyze the state's prescription opiate abuse problem in December of 2013, and in July, they released the guidelines. Again, key practices are outlined in this guideline. Before initiating chronic opiate therapy, document the patient's history and complete appropriate testing. Use a valid screening tool to determine the patient's risk. Consider initial treatment as a therapeutic trial. The opiate selection and dosage must be patient-specific, and avoid total daily opiate doses over 100 milligrams per day of oral morphine or its equivalent. In Tennessee, in July, they released their statewide strategies for success. There are 7 goals and strategies for achieving each of those goals. We're going to talk about 2 of the 7 goals. Goal 3 is to decrease the amount of controlled substances dispensed in Tennessee. The strategy goes right along with what Dr. Santos just covered, and one is to complete the development of guidelines for prescribing opiates and encourage adoption. Another strategy is to have the licensing boards continue to review their own policies and procedures around unsafe opiate prescribing practices and enact new rules that allow better self-regulation of licenses. Goal 7 is to expand collaboration and coordination with other states. And the strategy for achieving that touches again on something we've talked about, and that's the prescription drug monitoring programs. Develop a memorandum of understanding with other states, so doctors such as Dr. Santos mentioned, in Illinois, being able to access information from Wisconsin and surrounding states. Another statewide initiative to address the opioid crisis is the adoption of pain management clinic laws. This started in Louisiana with the adoption of 2005, and then in 2010, Texas and Florida had a law that went into effect, and this year, 2 states have laws that went into effect, Alabama and Indiana. There are commonalities between these pain management clinic laws. The first fundamental starts with you have to define what is a pain management clinic law in your state. Some states have a broad definition, as in Louisiana. Other states reference specific types of drugs or specific classes of drugs, and in some states, the definition of pain management clinic law is not limited to just the practice of pain management, but includes advertising as well. And these laws also have CEU or training requirements for pain management staff and or owners. And ownership is defined. Some of the states require that a physician own the pain management clinic. Other states that don't have this requirement do have a requirement that states there must be a medical director and outline the medical director's responsibilities and training requirements. The laws also have inspection authority. Some states allow the clinics to be inspected randomly. Other states have regular intervals, and some states' inspections can be based upon, can be complaint-driven. The last area is the PDMP registration. In a couple of states, if the physician is dispensing, the physician is required to check the PDMP. In a couple of other states, they require that physicians in pain management clinics must be registered with the pain management clinic laws, or pain management clinic prescription programs. And I'm going to turn it over to Phil to kind of give us an overview of those programs.
Thank you, Jaylene. Prescription drug monitoring programs have received and continue to receive a lot of attention, and rightfully so. These programs are definitely a step in the right direction, but I don't think they are doing everything that was expected of them, and I don't think they're doing all that they could. Part of that is based on the fact that we are dealing with multiple states. This is not a federal type regulation, but it is being driven at the state level. So there's tremendous variation. Currently, 49 states do have a PDMP, with Missouri being the last holdout. Quick comment on that. I have heard the DEA comment that they're concerned that the lack of a PDMP in that state could actually drive some of the bad practices in pain management to that state, so just something to watch out for. But then after that 49 is where the variations start to come in. So all 49 states are requiring pharmacies both in and outside the state, in other words, mail-order pharmacies, to contribute data. Only 37 are collecting data from both pharmacies and physicians. That leaves a gap in states that allow physician dispensing, that not all physician dispensed prescriptions are reported to the database. 22 states require prescribers to check the PDMP. Again, in an ideal world, that would be universal and not just 22. And then 26 states are currently participating in something referred to as NABP PMP Interconnect. NABP is the National Association of Boards of Pharmacy, and they have been very proactive in trying to remedy some of the interstate variations and shortcomings. And their prescription monitoring program, Interconnect, is a way to overcome some of the privacy concerns and allow physicians that practice in one state, especially if they're in a border town, Cincinnati being a great example, but need to access the database for a patient that resides in another state. The Interconnect program is making that possible. With all that said, though, I still hear two primary sources of frustration. Number one is regarding access to these programs. Two very significant entities cannot access the PDMP. First is insurance companies. Insurance companies are experts in identifying fraud and abuse, and yet they do not have access to this very powerful tool that could provide them with significant data in that regard. The other are the entities that can access it are law enforcement, physicians, and pharmacists. And actually, I should say physicians, prescribers, because nurse practitioners and physician's assistants that prescribe can also access the database. However, when it comes to pharmacist, the designation is dispensing pharmacist. What that means, the significance is that pharmacists that do the dispensing can access the database. That's very important. However, a clinical pharmacist, such as the ones employed at myMatrixx, when conducting a clinical review, says they didn't actually dispense the medication, they can't look at the data contained within that database. Second comment on this comes from Brandeis University. That university has a center of excellence with regard to researching PDMP programs, and they have published an excellent white paper on this And they are, just as I have described, are looking at these shortcomings and trying to figure out ways to improve upon this. One thing, and Jaylene is going to comment on this again later, has to do with something referred to as unsolicited reporting. The way the system currently works is a physician, law enforcement, or pharmacist has to go to the website and on their own identify areas of concern, red flags, etc. Unsolicited reporting would be more of a data mining approach where we actually use the data to identify these concerns in advance. Now, with that, Jaylene, I'd like to turn it back over to you to talk about some of the legislation that's going on with regard to PDMPs.
Thank you, Phil. PDMP legislation was very popular in 2014. A number of states adopted bills directly related to it. Some of them related to the frustrations that you talked about, Phil, with regard to more frequent reporting, requirement to obtain PDMP reports before prescribing certain drugs. The District of Columbia created a PDMP. There were a couple of laws that were specific to workers' compensation. One was in Arizona that requires physicians that are treating workers' compensation patients to check the PDMP within 2 business days of writing and dispensing initial opioid prescriptions. And the law also outlines when those physicians share that information with insurance companies and or self-insured employers. In Ohio, there was a law passed that requires managed care organizations to enter into a data security agreement with the State Board of Pharmacy. And lastly, with regard to the unsolicited reports authorized, as Phil mentioned, this is a very important area. An unsolicited report means that the PDMP program has defined the criteria to identify patients at risk. And if the patient is at risk, an alert goes out to the physicians treating those patients, encouraging them to check the PDMP so that they can, in fact, determine all the drugs that the patient is receiving and not just those that were prescribed by that particular physician, which is critical when it comes to physician dispensing, which was another area of legislation. Legislative activity that we saw in 2014. There were a couple of states, Indiana and North Carolina, that adopted laws that that limit the time frame of in which physicians can dispense. Indiana is limited to the first 7 days, and North Carolina for Schedule 2 and Schedule 3, it's limited to initial 5-day supply. There's also legislation pending in Pennsylvania, House Bill 1846, that the country is watching to see what will happen with that legislation. An area of regulatory authority that's received a lot of attention in 2014 are treatment guidelines. We've spent a lot of time talking about them today. California and New York both have treatment guidelines today, but they have both published proposed treatment guidelines of interest. In Oklahoma, the new Oklahoma Workers' Compensation Commission adopted ODG's in-drug list for patients for patients with injuries February 1, 2014 and after. And there are several other states, including South Carolina, Michigan, Minnesota, and Maine, that are looking at either adopting or revising existing guidelines. So Phil, I'm going to turn it back over to you to wrap up and talk to us about some state-level changes in controlled substances.
Okay, excellent. Thank you, Jaylene. And it seems we've gone full circle. So we started off today talking about scheduling changes at the federal level coming from the DEA, and now we're going to wrap up looking at some state-level changes. State-level changes are very interesting. Up until about the last couple of years, I would have said that a state can change the schedule of a drug if they're making it more strict than the federal schedule. With the advent of medical marijuana, that is the first time I have seen states actually go against the DEA and actually try to lessen the schedule of a drug. But other than that one exception, we do typically only see schedule changes at the state if they're becoming more strict. And that's exactly what's going on. Taking, for example, in Louisiana, they are looking at adding the immediate precursor to fentanyl to make it a Schedule II drug. They're looking to move chrysoprodol, this is generic Soma, to a Schedule II. They're also putting a limitation on the prescription date. Cannot be filled more than 90 days after that. In Florida, outside of the schedule, we're looking at not requiring reimbursement for certain types of drugs, including medical foods, vitamins and nutrients, and dietary supplements. Medical foods is an interesting category, probably worthy of a webinar all on its own. There is legislation that allows for medical food, but that designation is based on nutritional needs. What we've seen in comp recently is where actual drugs are being mixed in with the nutritional supplement to try to get around the other laws that regulate drugs. So very interesting way to handle this. Now to sort of wrap this up before we get into some of the questions, we've covered a lot of information today. And I just want to make sure the audience is aware that we do have resources available to you. If you go to our website, which is mymatrixx.com, mymatrixx.com, and click on our tab for Insights, you will find the chart that we referred to today regarding the prescription drug monitoring programs. We also have a chart outlining the treatment guidelines, as well as sort of what we refer to as the current state of physician dispensing. This is something that continues to change. Then in addition to those, there's also a number of links available in the slide presentation. One is to the Federation of State Medical Boards, another regarding PDMP training, and then as Dr. Stanos referred to, the National Alliance for Model State Drug Laws, all of which would be able to give you more detail on what you've seen before. Now, getting into some of the questions that have come in today, and first of all, I want to start off just by letting you know, if we do not have time to get to your question, please know that you can email us after the session to regulatory@mymatrixx.com, and we will follow up personally with you on those. Another thing, I know I'm seeing a number of sort of recurring themes in the questions regarding CE credit. So at the conclusion, we're going to go over the details of how to make sure you get your credit for the class. And then as far as the slides go, today's presentation has been recorded and will be available on our website for anyone that's interested in seeing that. Now, looking at the questions. First one, and I'm going to direct this to you, Dr. Stanos. If a historically compliant patient has been on regular opioid therapy and a doctor wants to do an occasional confirmatory drug screens, should he or she order everything, or should they just ask to screen select drugs in the urine drug test?
That's a good question, because I think it underscores that there has been, in some cases, I think physicians taking advantage of the use of urine screens. But if even patients that there's no risk factors, or you feel like they're doing the right thing, you can always get fooled. And so I think in those quote-unquote stable patients, you want to do periodic urine screens, whether it be once or twice a year. We get a urine tox screen and then do confirmatory for the drugs that we're prescribing. So I think that's probably the standard practice, is you're trying to confirm. Now, in the screen, you may pick up other drugs. So getting back to your question, I think you want to do a gas chromatography confirmation, and it should cover the medicines you're prescribing.
Okay, very good. I hear a lot of questions about the difference between the initial test and then the confirmatory test. And I think probably the basis of those questions all has to do with cost. Could you help the audience understand the purpose for the confirmatory test and why they may see another charge for that?
Well, yeah, that's a good question, Phil. So the urine screens, which I think a lot of times, and again, physicians many times need to understand the basics of this, as well as the other stakeholders. you order a urine screen, it mostly gets the Federal 5, and that would be a standard urine screen that any of us would have if we had a new employer physical. And all that does is work as a screen to look for drugs of abuse, illicit substances. So that screens for alcohol, in some cases, I'm sorry, barbiturates, opioids, marijuana or THC, Ritalin or stimulants. And so that's just a quick screen. And many of the synthetic opioids, unfortunately, won't get picked up on a screen of that nature. So you get the screen, and then with the screen, the next test is gas chromatography, which increases significantly the sensitivity and specificity. Even though that being said, there still can be some false positives. So the typical protocol is you get a screen, and then you have marked down what medications the patient's taking, and then you ask for confirmatory. That being said, many times you have to redo the test if there is a false positive, and so those are things you have to consider. These urine screen testings aren't perfect. They have to be done the right way, and then you have to understand some of the limitations. The one last comment I'll make is there's also, if it's not done by a specialty clinic, a specialty center or testing center, many times the thresholds for picking up a medicine with the screen can vary. So physicians or prescribers need to be aware of some of the basics with the companies that they're using, especially if they're not using one of the specialty urine companies, because many times that can lead to false positives or false negatives.
Okay, very good point, and just a quick comment on that, because there are multiple companies out there, and most of these companies today will enter into contracts with payers that will basically lock in prices. Oftentimes the price will include the confirmatory test, and very often it includes what is referred to as a workers' comp panel, which includes multiple drugs. It's just important, if you look at those contracts, to make sure that you know exactly what is covered in a panel like that. And Dr. Stennis, it seems we're on a theme here. This must be a hot topic for the audience. Multiple questions coming in about urine drug testing. We probably should do a webinar on this one topic in the near future. So the next one in this regard has to do with, are there rules about dispensing controlled substances or narcotics to individuals that have failed drug screens for illegal substances?
Well, I think, going through most of the guidelines, there's pretty specific wording that if a patient has an illicit screen, or their screen has aberrant evidence of aberrant abuse, that you, in some cases, don't have to prescribe, and/or they need to be referred to a pain specialist or addiction specialist. And it's pretty clear in most of the guidelines about that. Because the other thing is this: you use a urine screen to pick up not just diversion, but maybe the person does have a legitimate addiction problem or an addiction to another substance, and this might be the first clue you have that they have a problem, and then you can treat them. And a patient with an addiction problem, or a person that maybe had an addiction problem to an illicit substance, then was placed on opioids, and then starts to misuse that previous substance, they're struggling with an addiction problem. And you as a physician, maybe the first way you're going to find out is with an abnormal urine screen. The worst thing you can do is kind of kick the patient out and not follow up on it. And actually that in itself is outside of the standard care. So if there is an illicit substance that comes up, you need to assess what the real problem is. Do they need treatment before you do anything else? Which I think a lot of times gets missed, and many times patients with an addiction problem or an illicit substance in their urine are just discharged from practice, and then they're at high risk for themselves, and/or they're just going to go to another pain clinic and continue to cause problems.
Okay, thank you very much. I'm going to ask you one more question on urine drug test, and then we'll change to another subject before we run out of time. The last one on the urine drug screening has to do with clarification on requirements versus guidelines. And keep in mind, oftentimes our clients are paying anywhere from $350 to over $1,000, even $2,000 for these tests. And the claims professional may hear comments that it is mandatory that these tests be done. Are you aware of jurisdictions where this is truly mandatory, or is it simply a matter of interpretation of the guidelines that may be out there?
I'm not sure if I'm familiar with where they said it's mandatory, but I think it is within most of the guidelines that urine screening be done as typical, or the basic monitoring for diversion and misuse. but I'm not sure, maybe Jaylene can comment where it says specifically. I think some states do comment on how often they should be done, whether it be once every 6 months, once every 2 or 3 months, and or if it's a problematic user. So I'm not sure if that wording has been used, but I think in most cases, if we were reviewing a case, if they're not doing urine screens, if you're not doing urine screens, there is no way you can say based on your own assessment that the patient that the patient's not doing anything inappropriately. So when I'm reviewing cases and I get cases that are sent to us, I'm still amazed sometimes the patients are on opioids for years at a time and a urine screen hasn't been done. And that's a huge red flag.
Yeah, I would agree. And Jaylene, I've reread this question, and I see now that the participant was actually asking if there are any requirements that urine drug screening be done monthly. I'm not aware of guidelines or requirements for monthly testing.
Nor am I.
Okay.
Yeah, and you know what? I agree. And I think I remember one case where a physician every month was doing a urine screen. The patient wasn't even on opioids, and I think every month he seemed to have a different company he was using. So I mean, it was just, it made me understand what's the context of how they're doing the urine screens. There were other issues with this prescriber and what he was doing in his practice. I think it was beyond egregious use of not only urine screens, but how he was doing other things. So I think a urine screen has to be done and reviewed within the context of everything else. And I think that means, are they assessing the patient? What other kind of treatments are they getting? And again, the urine screens are just part of the whole picture.
We are approaching the top of the hour. I think Dr. Stano said we have time for one more question, and I'm going to shift gears, and we're going to look at MED for a moment. And for the members of the audience that aren't familiar with that acronym, it stands for morphine equivalent dose. There have been studies done that indicate that when the morphine equivalent dose exceeds 100 to 120 milligrams of morphine per day, that the patient is at a 9-fold increased risk of overdose. So with that, Dr. Stanos, first part of the question is, how can the claims professionals address issues with physicians that are prescribing amounts that are significantly in excess? The example in the question is 540 MED per day. As I've discussed with you in the past, we've seen patients in the 2,000 to 3,000 MED range. Is there an appropriate way to handle a case like that?
Well, yeah, and I think maybe I failed to mention this when we talked about some of the guidelines. Most of the guidelines talk about any opioid, regardless of the dose, should only be continued if there's evidence of at least stable or improved function. And so I think a lot of times that gets missed. There's nothing documented that are they getting any benefit from the medicine. I still think the dose limitations are somewhat problematic because, again, it may lead to a false sense of security because people can still have problems at lower doses. The literature on increased dose with increased depth is very controversial. I was at a recent FDA meeting in May, and the FDA is trying to look at this because a lot of the data is very hard to look at because you have prescription overdose, you have drug addicts with overdose deaths. So the data has been very mixed, and so it's really hard to tell. There's a correlation, but many times the correlation is only a correlation because a lot of the data does not reflect on psychiatric comorbidity and some of the other factors. So I think we really need to proceed with caution. Now, this patient that's on 540 milligrams, are they really getting a benefit? I do think in what we've seen in the last year that I'm not seeing, at least in our clinic and especially in Illinois, we were not seeing these real high doses that we were seeing 2 and 3 years ago. So I think the old thought of just give a high dose opioid and keep increasing the dose until you get an effect, hopefully physicians are shying away from that and we're not seeing dose escalation. But again, getting back to your question, I think you have to look at the case. Are they getting a benefit from it? Are they doing urine screens? What's the real story here? Is this diversion? Is it appropriate use? Because, unfortunately, from the cancer literature, there is variability, and some patients, we've learned from cancer pain, may require high doses to get an effect. I don't think that's where we should be going, and again, I think it goes back to, and I'm sorry to be long on this, Phil, is going back to a trial. Patients put on the medicine. If they don't do well at the lower doses for those first couple of months, just increasing the dose in itself, I don't think many times is helpful. Many of these patients at high doses may develop opioid hyperalgesia, and they may be presenting more with a hyperalgesia problem versus a tolerance problem. So again, that's something we didn't talk about, but I think the high doses many times can be more of a hyperalgesic effect. And those patients should be detoxed or sent to a tertiary care center to be better evaluated.
Okay, excellent. Thank you so much, Dr. Stanis. We appreciate your participation, and Jaylene, we appreciate yours. For the audience, just a reminder to register for the CE credits. If you were a participant today that registered for the webinar, you will receive an email this afternoon that will give you a link to accomplish this registration. There will also be a survey included. We really appreciate your feedback, not only on today's webinar, but on topics that you might like to hear from us in the future. And then lastly, as a reminder, the webinar has been recorded and will be available in the very near future on our website. Thank you to everyone that participated. Bye-bye.